Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. It is a lovely, extremely beautiful day here in Northeast Florida. OMG. Everybody, are we in January or what? What happened to last week?
Let us stay in last week.
This was an absolutely Florida picture perfect day. Or I should say a picture perfect weather day here in Northeast Florida. We have a wonderful conversation scheduled for you all tonight. If you joined us last week, we began one of my favorite subjects and probably one, Dr. Mills, that I'm gonna have forever unless I come to see you and the folks at what is it, Slim what?
Limb
Slim.
Glow Medical, yes.
Okay, exactly. But anyway, before we bring you all in, I would like to, of course, bring in my co-host, Dr. Kane. How are you doing this evening?
Dr. Kane is doing absolutely fine, enjoying the weather. I'm stressed out a little bit with what's going on in DC as far as my patients are concerned. This is not a political thing right now. This is all about what's the safety for our patients and our families, as a matter of fact. So I'm a little bit distraught about some of that BS. Excuse the language, those that are ears sensitive. But I'm a little bit distraught about that. But other than that, I'm glad to be here. Excellent weather. And I am happy to be talking about this subject matter because it's been long overdue.
Yeah, and what you're referencing really has a lot to do with the uncertainty. It's what we don't know. I think that makes us so at ease.
Yes.
Ill at ease or whatever. So, but anyway, enough of that foolishness. So again, tonight is such an important topic. I mean, it's one that if any of you have heard me talk about it in the past, my particular health issues, you'll know that I am no different from most people in that I struggle with things, and being overweight is one of them. Despite what I've been told by people who care about me, I don't know if they care about me, Dr. Kane and Dr. Mills, but they used to always say, "Oh, you big boned it." I'm like, "No, I'm not. Look at that wrist. Look, that is not a big boned person, but I'll take it, right?" So anyway, but we're excited to have a distinguished panel of guests, starting with Dr. Wesley Mills, who joined us last week. As you heard, he is in private practice.
Week before last, sorry.
Excuse me, 2 weeks ago. See what the weather did to me last week. But Dr. Mills, for those of you who joined us 2 weeks ago, is a primary care physician here in Northeast Florida, but he has ventured into another business and co-owns. Dr. Mills, take this opportunity. Go ahead and do a shameless plug about your new business.
Yeah, okay, I will. So probably about earlier this month, we finally were able to open. So my wife and I own this medical spa. It's called Slim Glow Medical. So our Centurion Parkway. So right now we're doing medical weight loss, and we're going to add some other services in a little bit, but that's where we're starting. So this talk tonight's perfect, actually.
Fantastic, fantastic. So we'll be happy to hear about that and bring you and your wife back on the next time as you really get into knee deep into the business. And of course, joining us for let me see, is it the 15th time, Dr. Kane?
About that much, maybe 20.
Is Linda Lockett Brown, our favorite registered dietitian. How are you doing this evening, Linda, with Sinette? Did I say it right?
Yes, you did. I'm doing well.
Sinette registered dietitians and something and more something.
Wellness.
And wellness.
Well.
So we are happy to have you joining us again tonight. And our new friend and I'm hoping that I do not botch it up. I'm going to say it
I
how
can't
I
wait to
think,
hear it.
Rebecca. Rebecca Goldfaden.
That's close enough. I take anything.
Gold,
Goldfaden, but that works. No, I'm
Goldfaden.
excited to be here. I've known Dr. Kane probably for about 12 years.
100 years.
So, yeah, it's been a long time. So I'm excited to join you guys tonight.
And Rebecca is of the panel tonight. Rebecca is a pharmacist. So we are super excited. You know, Rebecca.
From my alma mater.
Oh, is she?
Okay.
Okay. FAMU, huh?
Well, our company was founded by a FAMU grad. Yep.
Oh, cool beans. Well, thank you. Thank you for joining us for the first time. But fair warning, when you come on one time, you're just hooked. So just already know that we're probably going to have you back on.
Love it.
Rebecca, I'm going to start with you because a topic that is so important now that a lot of people have been talking about, and my phone would be ringing. Like everybody who knows me, no, don't call me this time of night. But a very important topic that we've all been talking about, I know in my circles anyway. So I'm just going to go ahead and let's start out with the GLP-1 receptor agonists and GIP-based therapies. How do they work in promoting weight loss? And first of all, tell our audience who are just so oblivious to what those are. Tell our audience about those particular medications.
Yeah, no, of course. So the GLP and GIP, they're glucagon. They're incretins that are typically released from the gut in response to food intake. And so when you eat, your body will typically release these, and they work in a lot of different areas of your body. They work in your brain, they work in your stomach and your intestines and your fat tissues. And they have a lot of different mechanisms to help make you feel full and to hopefully reduce the amount of food that you eat. However, in some people, these hormones that we call them, these incretins, these things that are released in response to food, don't work the way that they should. And so while maybe one person can eat food and they feel full and they don't eat anymore, someone else might not get that same response. And so they, kind of feel the need to continue to eat more. And then also with how your stomach and your intestines digest the food, it reacts a lot differently. And so basically these medications, the GLPs that we hear that are so big right now, you're injecting or you're taking by mouth, you're taking these incretins, you're taking these hormones and you're putting them in your body to offset to kind of help if you don't have as many of those incretins or those hormones in your body. And so it helps you feel full faster. It slows down how fast your body breaks down the food, and so that you kind of feel full. It helps with your fat tissues and different things. And then another big thing is over the years is they found not only does it help with your blood sugar control and your fat and weight loss, but it actually has some heart benefits. So there's a lot of different things that these medications do that causes a lot of people to want to have access to them.
So what are some of the popular brands that
I'm just gonna tell you, those people that for those that are not familiar with it, those brands would be like Ozempic and Zepbound. Some people the most infamous one everybody knows about is Ozempic. Okay?
Yeah.
Everybody knows about Ozempic.
Ozempic.
Yeah.
Exactly. Ozempic, Wegovy, Zepbound, Mounjaro, and a lot of these, sometimes they have one name if they're used for diabetes and another name if they're used for obesity. But in actuality, it's like the same drug, just has two different names. But there's quite a few on the market now. But the biggest one is the Ozempic.
And quite a few coming out, but
yeah.
And Dr. Mills, are you getting a lot of requests for those in your practice? Are people coming in requesting them?
So all the time. So, like you said, Dr. Kane and I, we've been using this for a long time for diabetes. The earlier ones were just daily medications, the Victozas, the Bietas, the Bidurians. They were just daily medications and they didn't have as much weight loss. So they weren't popular for weight loss back then, but literally on a daily basis, which is kind of the impetus behind me asking my wife, hey, you want to do something, because I kept having all these patients like daily want to be on these medications for weight loss, and the majority of insurances just don't cover it. So for diabetes, they'll cover it, but even with diabetes now, we still have to do prior authorizations, even for our diabetic patients. So, but the majority of companies, or most insurance companies, they're just not covering it for weight loss. I mean, I may have maybe 10-15%, and I don't know, Dr. Kane, I don't know what number you're seeing, but maybe 1 or 2 out of 10, their insurance covers it for weight loss. The majority just don't. And so I was trying to figure out how to get them the medication. So I was trying to send them to the med spas or weight loss clinics. And so that became the problem. And so that's kind of how we end up with Slim Glow Medical, just because of that issue. But yeah, it literally daily someone asked me to be on, to try to get on these meds, and we just have so much trouble with coverage.
Why is it so difficult to get? Why are insurance companies not covering it if people with diabetes particularly can benefit from it? I mean, obviously forget the weight loss part of it. To me, that's an added benefit. But if it helps someone manage their blood sugar, then why would it be a uncovered medication?
It's all cost.
Mm-hmm.
So say a patient has diabetes, and Dr. Kane, we're kind of slick sometimes. So say the patient comes in, they're a little bit overweight, or they're a lot overweight, but if their blood sugar, say their A1Cs are too well controlled, it'll get denied. And that never used to happen. But this,
Wow.
since everyone wants to be on these medications, because they're like, you guys are trying to backdoor us and try to use this for weight loss and not really for diabetes, which is true, but it really helps out multiple things, because, now, as they lose weight, maybe their blood pressure goes down.
Mhm.
Their cholesterol probably gets better. If they had sleep apnea, now they don't have sleep apnea anymore. So it's really beneficial in multiple, ways, but, the insurance companies are still looking at their bottom line. So that's why it's kind of hard. But for weight loss, the majority of them don't cover it, because these medications, and like Dr. Goldfein will tell you, these meds are at least, I mean, the brands are at least $1,000 a month, and then up. They may have some coupon cards where you may get them for $500, $600, but as you go up in the dose, they could get up to $1,600, $1,700, $1,800 a month. So they're very expensive.
Oh, wow.
Hey, Dr. Goldfein, explain to our audience, why is it that the generics are available, if you can.
Because there's a shortage of the medications. So then, since there's a shortage, the FDA allows the compounding of these medications. And so obviously there was a big demand of the medications, and so it put the supply down. So while I think it's just semaglutide is on the shortage, and possibly tirzepatide, but Dr. Mills probably knows that better since he's in that business, but that allows them to be able to compound it.
Yeah, so what's happening now, you guys, and starting in the middle of next month, tirzepatide is coming off. So the compounding pharmacies won't be able to do that for at least for a while. We don't know how long. Semaglutide still they'll be able to do, but the compounding pharmacists, they're pretty slick about certain things too. So they have ways around some of these things, but they're still oral medics, because some of these they'll have like oral tirzepatide, which we don't have, commercially. So there's other ways that they do it. But the problem is, like you said, I understand people's concerns. It's just that the medication is so expensive that it's cost prohibitive if you don't have insurance coverage for them.
So Linda, I got to come to you.
Okay.
What are the biggest challenges your clients face in maintaining healthy eating habits, and how do you help them overcome those obstacles?
Well, what I'd like to do is back up a little bit and talk about how we got here in the first place. So we've done a couple of shows about ultra processed foods. And so the way the body is designed is to have on-off switches, and these on-off switches actually work in milliseconds. So when your body responds to blood sugar levels, whether they are up or down, and your body, if your blood sugar is up, then your body will respond by releasing insulin. If your blood sugar is low, your body will respond by releasing glucagon, which tells the liver to release some blood sugar just so you don't pass out, so that you can stay stable. Where the ultra processed foods come in, they come in at two levels. One level is because they are processed so quickly, it basically short circuits the ability of the body to respond to what's happening. Because normal food, if you ate an apple, it's going to take your body some time to digest the apple. If you eat applesauce, the time is less. If you eat one of those squeezy things that people give their kids, it's very little apple in it, it's mainly
Go-gurt.
sugar. Um, thank you. Your body's going to process that even faster. So that's one level of the problem. It is the ultra processed foods. The second level of the problem is those foods are formulated to stimulate receptors in the brain. And the receptors that get stimulated are the same receptors that are stimulated when you do cocaine.
Crack.
It's the same receptors. So here you have humans running around that have their system short circuited by what they're putting in their mouth. So that's one issue. The other issue is these on off switches, we're talking nanoseconds. So when your body releases a hormone, your body, it was never designed for a hormone to be floating around for 7 days. That
Mm.
is not the way the human body works. So, when you have a medication where you are injecting the hormone, it is on board, it is active for, depending on which one you're looking at and depending on your own body, 4 to 7 days. That's like turning on a light switch and leaving it on. Your body is not designed for that. So, even though there are people do lose weight. There is no doubt about that. People lose weight. But what I'm seeing in my clients is I am seeing muscle loss. I'm seeing muscle loss and I'm seeing malnutrition. So if they're
Mm.
in the category where they are responding to those receptors in the brain that are the same as the ones for cocaine, I see people literally starving. They have very little interest in food whatsoever. And when they do eat, what are they going to eat? They're going to eat carbs. They're going to eat carbs because they're trying to do something. So a lot of the data that's coming out now, it's saying that if somebody has an addiction to cocaine or heroin, you can give them a GLP-1 and it will decrease their addictive behaviors.
Wow.
So that's part of my issue. Here's my other part. It's hard to get the drugs covered, as we've already discussed. But when the drugs get covered, what is not covered is going to see a dietitian. So I deal with the same population that Dr. Kane does. A lot of my clients are older. And so you take an older person, you put them on a medication that one of the potential side effects is that they're going to lose muscle. That increases their frailty. And that's the other thing that I'm seeing. I'm seeing people take the drug, lose weight, and 1 month they're upright and walking. And the next time I see them, they're on a walker because they're so weak that they can't even stand. So if you ask me, is that an okay price to pay for weight loss? I say not. I say not. So I'm always a solution focused person. So part of the solution would be what we did when people were going for bypass surgery. If you were going for bypass surgery, you could not get approved until the dietitian evaluated the client and signed off on it. And so what I did when I signed off on it is I had a protocol and I showed people how to get adequate protein. We talked about physical activity, and we talked about what to do when you get in trouble. And so, is there a happy medium? Yes, there is. But we're back to people are going to have to pay out of pocket to see the dietitian, because the three largest carriers, insurance carriers in our area, don't have dietitians on their panel at all. So people are going to have to pay out of pocket. So that's my soapbox. But I'm just really concerned because I've seen the muscle loss in many of my clients, and I'm seeing it after the fact, and they're all happy that they lost weight, and they look horrible. They look horrible.
That's not the goal, Linda. The goal is to look magazine ready.
I mean, I think there's always you know the patient-centric approach. So you have to kind of look at the patient as a whole, and as a healthcare provider, whether you're a pharmacist or a registered dietitian, an MD, is see if this is going to be potentially beneficial, and monitor them throughout the time. What's their goal? What's your goal as a provider, healthcare provider, for these patients, and not let them just continue on a negative slope there. So
I think,
Rebecca, how do you determine which pharmacologic therapy is best suited for a specific patient?
Let me intervene a quick second before you ask that, because I'm gonna put it to Dr. Mills and myself, because as clinicians, we're not disagreeing with what Linda says, for sure. Okay, we have patients that will be of concern, whether or not it's because of marasma-like presentation, due to lack of adequate nutrition, protein, yada yada yada. We have those patients. Those patients are determined. We're looking at the other side of the consequences for obesity, in terms of what happens to these patients if they don't lose their weight. Sleep apnea, all the knee issue, you name it. We talked about that once before in terms of what happens with obesity on the last program. However, one of the reasons that and Dr. Mills can speak for himself, but one of the reasons that I think most physicians like Dr. Mills and myself, the ones who are really all about the health and wealth of the patient, we want to make sure that, because these patients are going to go out there and get them online, they're going to go out there and get them from other people, and what we want to make sure is we take a holistic approach, right? And Dr. Mills, again, you can speak for yourself, but we want to take a holistic approach in which we're monitoring those patients not only for the weight loss, but their protein intake, their carb intake, their fat intake. You check for their lean body mass. Mm-hmm. When you want a comprehensive program to utilize these GLP-1s and and GIP, like I say, GIP and GLIP. If you want to use these medications for weight loss, we have to make sure that it's in the best interest of the patient in the long run, and not just plain weight loss. So I can't wear the head of a dietitian, even though they try to force us to, but we grab dietitians. We grab pharmacists who are into and know a lot more about these drugs and the holistic, the wholesomeness of all those drugs, as opposed to just knowing about one particular drug that sometimes physicians like just writing for one drug. And that's what they specialize in. So I just want to make sure everybody understands that if you're going to do these you're going to do these drugs as diets, for dietary, for weight loss representation. They didn't need not just to be ordering them online from somebody and experiencing the consequences of what Linda talked about. Dr. Mills,
I was going to jump into you guys, because another thing I tell people all the time is you're typically, unless you're on these for diabetes, you're only going to be on these a short period of time because these medications are so expensive. You cannot be on them, in perpetuity. It's even the insurances that are. This is another thing I'm seeing. Some of the insurance companies that are covering them they'll give them a max. So it's basically like they're saying, okay, either you can have bariatric surgery, which costs $20,000, or there's a $20,000 cap on you getting using the GLP-1
Gotcha.
agonist. So either one, you can do it either way. But so after a certain period of time, you're gonna have to stop these medications. And what I preach to the patients all the time is you have to be able to maintain this weight once you finish. So which means you need to be trying to eat healthy. You need to exercise. Because what is the point of being on these medications, losing 30 pounds, and then you stop it, and now you're up 10 pounds from when we first started,
Right.
which is what I used to see all the time on Adipex or Phentermine. But any of these medications that are like that, I mean, because again, they're artificially suppressing your appetite. So it's easy to lose weight, even if you eat horribly still. But once you stop those medications, you want to be able to maintain them because you don't want to have the yo-yo diet. And so that is one of the main keys. And like Ms. Brown said, you have to be monitored. And if you're doing all these things online and no one's monitoring you, you can just keep losing weight. No one's watching it. Dr. King and I, we're watching this. And so if you start to look like that, obviously we need to stop. We need there comes a time when you don't need to be on this medication. Unless it's for diabetes, then we might need to decrease the dose or figure out other routes. But left to some people, they'd be on the medications and fade away because everybody wants to lose weight. But sometimes we have to make sure we're doing it in a healthy manner.
But Dr. Mills, if people are being prescribed the medicine for diabetes, why is the weight loss portion of it the driving force to limit how long you're on it? If it's helping someone who has diabetes manage their diabetes, does the industry prefer that you take oral medications versus using the injectables to manage your diabetes?
They're not really stopping us from that part, Justin. So we can keep them on the medication. So the insurance companies really, once you start somebody on it, and even when we change the dose, they'll make us do prior authorization. So we do prior authorizations like all day now. Like it's continuous now. If they're on one dose of Wegovy or Ozempic or Manjaro, and we go up to the next dose, they'll make us do another prior authorization. So I think they want to they don't really want to keep using these things. So I think it's, but so they won't make us stop because the patient's losing weight. But if their blood sugars are really, say you came to me and you're diabetic and your A1C is 6.3 in the pre-diabetic range, they will probably deny that medication, even though you're diabetic, because they're going to say you guys are trying to backdoor this for weight loss. You don't really need this for your diabetes right now. And so they've gotten smart because, again, these medications are super expensive. That's the only reason. They're just really expensive. And so that's kind of the problem.
Yeah, and there's alternative medications out there besides, the GLP-1s and the injectables. There's, SGLT2 inhibitors or oral agents. And so like they'll probably require you to try and fail those medications before they approve the more expensive ones. So sometimes if the patient has like comorbidities like hypertension or chronic kidney disease, or they've had a heart attack, like it makes it a little bit easier to get those medications approved if they have those additional comorbidities. But it's kind of difficult sometimes, unfortunately.
It's not as difficult when they actually have the diabetes, okay, versus if, like what Dr. Mills and Dr. Goldfaden says, versus just for the weight loss. It's not as difficult to get it for them and keep them on it. Now, they still going to try to make sure you're not trying, as Dr. Mills stated, backdoor some things, okay? But these drugs are really pretty good drugs with a lot of other things, which we'll talk about later, because they reduce the risk and or treat other, have improvement in other medical conditions that we probably get into in a short order.
So, Rebecca, and if it's Dr. Goldfaden, I'm gonna get it right. Can I just do Rebecca and then we just be friends from this point forward?
That works for me. You can call me whatever you want.
So, what are the most important points patients should know when starting pharmacotherapy for weight management?
Yeah, so a lot of times they'll experience side effects, nausea, vomiting, diarrhea, constipation, all of the above. And so one thing, so I actually and work in clinical research. And so we run clinical trials throughout Florida. And we've studied these medications, semaglutide. We studied Ozempic before it was already on the market, 12 years ago. And so just working with these patients to understand that you're going to have these side effects, but that's because that's how the medication is working. The medication slows how long food is in your stomach. So if you're filling your stomach faster than it's emptying, like you're going to feel nauseous, you're going to have vomiting. And so it's not necessarily a bad thing. While the side effects are definitely bad, but it's just part of the way that it works. And so if you can work through those symptoms and maybe take some medications if it's really severe to help alleviate those symptoms and get past, it could be a week, it could be 2 weeks, it could be, maybe a little bit more, it will subside. Those symptoms will subside over time and your body will get used to those and you won't have the same side effects. And then there's things you can do, like eat smaller portions, eat slower, just different things so that you're, trying to reduce those side effects from occurring.
Let's talk about
being bad. If people stop being good cooks, then people just need to start being bad cooks, worst cooks of America throughout America, and then we wouldn't have this problem. Go ahead.
Well, but that might be easier said than done because, it's like me. I was running here today to get to the show, to get to the podcast, being very busy. So, do I run and grab, much as I hate to say
fast food?
Fast food. I was going to name somebody, but okay.
Don't name them.
I know you were going to straighten me out, but I'm running to grab these fast foods, which are high in carbs and high in, as Linda said, what do you call them, Linda?
Fat and sodium, ultra processed.
Yeah, ultra processed food. These are ultra processed food that's high in fat, high in sugar, high in saturated fats. The really bad stuff. Then it's a matter of convenience. Just real quick to understand, this is my perspective, what I say to my patients. To understand the side effects of these drugs, I make sure that they understand how these drugs work within a layman's level. They will turn an increase in insulin production, 2 decrease more or less, and Rebecca, you can straighten me out, decrease in glucagon production, which allows the liver to make less sugars and stuff by what liver does in terms of breaking down glycogen and also producing glucose from fats, glycolysis, glucogenesis type stuff. 2, it sends a message to the brain to tell you feel full, and then it sends a message to the GI tract to slow it down to keep you feeling full. That latter one is the one that's probably the one they experience the most, giving rise to things like reflux, constipation, and much of whatever the GI tract will offer if you monkey with it from that standpoint. However, some of that can be prevented, and I'm just throwing some out real quick. Anybody want to talk about it, they can. However, some of that stuff can be prevented, especially like the constipation, can be helped by using, things like Miralax, these high fiber or fiber-related
supplement.
The supplements.
Yeah, supplements. Those things.
Fiber. Yeah.
Right, for fiber and stuff of that nature. However, the trick winds up from a lot of my patients when they do that, I'm feeling, they're not really that good at taking, managing that stuff. And so we start getting those side effects. And, but that's, I don't want to relay or talk too much. I want my guests to go on ahead and contribute to that part of the conversation.
One thing that I found is a lot of times when medications have side effects, if the medication is for your cholesterol, if the medication is for something that the patient doesn't see themselves, then when they have a side effect, they're much quicker to stop the medication. However, these patients are eager to lose weight and they're seeing the weight come off and they don't care how much they're throwing up or how constipated they are going to stick to it until it gets really bad. But I mean, that's some patients. Obviously, there's some patients that, they start vomiting and they're done with it. They'd rather not lose that weight. But definitely, I think compared to some other treatments, I feel that patients are a little bit more persistent to those side effects.
Well,
Yeah,
one
I've
of
had
the
very
things
few
that
patients stop for whether it be on for diabetes or for weight loss. Very
Wow.
few. They will fight through it. And even the people, the majority of people you got, let's say have horrible constipation, which you can offset, like we said, by increasing your fiber intake, make sure you're drinking plenty of water, and I'm sure Ms. Brown can tell us even more things. But and if the nausea's out of control, you can always try something like Zofran. There's
Mm-hmm.
medications, but I'll be honest with you guys. I rarely have to do any of this stuff. I just think people just fight through it. And when they do have the nausea, I think most of the time they'll have it the day 1 or 2 of the when they do the injection, and it kind of wears off. But like you just said, Dr. Gofiden, I think people see such benefit from the weight loss that they're willing to put up with with the side effects because we put somebody on Crestor or one of the statins and they have a little twitch of their muscle and then I'll stop this.
They're done.
It's not the same thing with this. They're like, yeah, I threw it for 3 days, but I'm going to keep taking it. Can we go up on the dose? I'm like, wait, what? Yeah, it's a
Right,
little
they're
bit
allergic
different
to
now.
every single statin yet, like
Exactly.
Well, Dr. Mills, let me tell you before she does. Linda says if you have a problem with constipation, you get your 2 whole carrots and a bottle of water and go for a 30-minute walk and things will start moving. Did I say it right, Linda?
yes, you did.
All right. So anybody who's having a problem with constipation, go ahead, Linda. You were going to say something.
I'm thinking back to when people were going for bypass surgery, and one of the things we had to teach them to do was to always eat the protein first.
Yeah.
So you always eat the protein first so that no matter what happens, you have the protein in. So if your GI tract is slowing down, then you actually need to switch your source of protein or moderate it and go for plant-based proteins versus animal-based, because fat and protein in meat, they slow your GI tract down anyway because they are hard to digest. Your body needs to go through a couple more processes. So you take that normal slowdown and add it to the slowdown from the GLP-1 medications. It could be problematic, which may be part of the reason for the nausea. So one of the things that a dietitian could do would be to make sure that what you're eating is balanced, but then put time and effort into switching those protein sources to plant-based, at
Like
least
what?
some of them, because that way you're going to have less fat and they are easier to digest. So the other part of the equation is resistance training. And you say resistance training to some people and they're looking at you like, what is it you want me to do? Yes, I do want you to lift some weights, but we're talking about 2-liter bottles filled with water. And so you're going to lift those. You can buy ankle weights that strap them on. And when you go for your 30-minute walk, you're adding resistance. There are resistance bands that you can use. But I guess my concern is people just see it as some magic bullet, and it's not a magic bullet. You still have to pay attention to what you put in your mouth, and you still have to move your body. It's not magic. And because the using it for weight loss is so new, we in reality do not have long-term trials. We have some trials, but see, from my perspective, anybody can lose weight. Losing weight is not the issue. Keeping it off is the issue.
Well,
So that
you just went into to the next phase of my discussion, which is
okay.
maintenance.
Well, I
Okay.
want to get back to examples of plant-based foods. Like, what are plant-based proteins? I'm sorry.
So honestly, if I was going to do something with someone, I would have them do a soy based protein shake, or a pea protein based shake, or a whey protein shake. So those are
None of those
all
sound yummy, Linda.
Now,
None of
that's where
those
the
sound
problem comes
yummy.
in there. That
I
sounds
actually
good.
I have some pea protein chocolate milk, which is delicious.
Mhm.
Mm,
But the problem with
sign
this
me
is
up.
these things are expensive.
yes,
These
they are.
alternatives are so expensive where I mean it can't really be a replacement because geez, it's a ton of money.
And you're right. And I've had patients, um, when they get the email for them to order the item, they send me a text and they'll say, I can't afford this.
Mm-hmm.
So the problem that you get into is, like, if the person is diabetic, then the protein source would be legumes. And so legumes and brown rice,
What are
now you
legumes? What are
now you
legumes? What are legumes?
black eyed peas.
I just want to be sure our audience
Yeah, no,
connect.
no, black eyed peas, black beans, red beans, those kinds of things. So if they're diabetic, then we have to watch the portions. So it's all doable, but it's not doable without some guidance.
Mm-hmm.
So people can do fine with guidance, but I'm just concerned that they're not getting the guidance and they're just happy that the scale is going down. And so it's almost like you win the battle, but lose
Lose
the
the war.
war.
Yep.
So if
Well,
you're
that's what
just
Slim
tuning in, we're
Down Blow
talking
Up is
about,
all about. But
if
go
you're just tuning in, we're continuing our discussion on obesity with our panel, a registered dietitian, a pharmacist, and a couple of physicians. So send us a question. I know a lot of you may have heard or seen those commercials, Ozempic, Manjaro, and some of those other medications, and perhaps you've been considering using them. Now you have the opportunity to ask our panel about those, and that's what we've been discussing tonight. So if you've wondered when you heard the GIPs and the GLIPs that Dr. Kane referred them to, GLP-1s and GIP, because I know when he mentioned it to me, I'm like, who and what? You have to call it what we hear on the television commercials, Rebecca. Manjaro, Ozempic, those are two that I tend to remember, because Ozempic, because they have the coolest jingle that I
Oh.
sang a few minutes ago. But Dr. Hill, so when you and your wife decided to open your business, you opened that business as an alternative because you realized that and don't let me put anything, I'm not trying to misconstrue things, but is it just another option for people who were being denied by their insurance companies, and here you're now providing a place and space for them to deal with the whole part of weight loss?
a
Yeah,
safe
so
place and
oh,
space.
so what was happening, you guys, is literally I'm trying to write these medications because the patients come in and they don't have any contraindications, so they don't have a family history of a certain thyroid cancer or a certain endocrine issue, and there was nothing else that was precluding them from being on the medications. And I'm trying to write them the medication. The majority of them weren't covered. Like probably 8 or 9 out of 10 were not covered, and so then
Mhm.
I'm scrambling trying to figure out where to send them safely. And so a couple places I knew some of our physician friends who had a practice and did, some had like a med spa. So I was trying to figure out where to send, and I just didn't know where to send anybody because, through my practice and my office, my primary job, we're not able to use the compounding pharmacies like that. So I'm writing prescriptions to go to CVS, Walgreens, Publix, Walmart, and you go up there and it's going to be $1,300. You're about to be calling me back talking about, yeah, Dr. Mills, I don't think so. And so we were forewarning this, and I was trying to figure out where to send them. And then that was really where this whole idea came from. I'm like, okay, at least, you know, my wife used to run neurosurgery and primary care, so she does healthcare administration. And I was like, this would be a good thing. We could really, help some patients out and help them do this safely. Because, like I said, sometimes some of the stuff I just can't do for my own office, and I know Dr. Kane runs this as well. Like for my primary practice, some of the stuff, if your interest isn't covered, I can't really do much. So this gives another alternative route to be able to safely help patients and, advise them. And again, everybody, this is not for everyone. And I tell everybody, even though it's less expensive using the compounding pharmacy, it's not inexpensive. It's two different things.
Yeah.
Maybe it's a half or a third of the cost, but it's still expensive. It still may cost you $300 to $500 a month. So the stuff is still expensive, but it's more doable, but it's still very expensive.
I'm just speechless. I just can't, I think about the conversation that we had about people with comorbidities. If you have sleep apnea, high cholesterol, high blood sugar, and you happen to be obese, to me, that's a no-brainer. So I can't, even though someone may have an A1C of less than 6.5, but if they're taking medication and using the CPAP machine, for example, on a regular basis, I can't imagine why they would be denied. And then you have a strong family history of those diseases. Maybe you haven't had your first heart attack or stroke, but you can look back not too far in your family lineage and see that those things, if these diseases today are not managed. So I'm just amazed how the insurance companies, and sadly, Dr. Mills, I think, and all of you, I think a lot of it is because of abuse of people who really didn't need the medication in the first place. And now those who found out about it and need it, they're being denied because of the okay, I won't say it. The not so fat people who were taking the medication to stay thin, the thin people who were not thick and decided to take it, and now they've oversaturated the market. And it's not made available to people who could really, really benefit from it and manage their chronic diseases. Dr. Kane, you laugh, but I'm telling the truth.
But no, those people that are not big boned, as you were saying, that's why I was laughing at. Those people that are not big boned, but in truthfulness, I mean, you're right on point. There are people who need it for other medical conditions, okay? Not just a comorbidity, meaning diseases associated with your primary issue, or of hypertension or heart disease, but there are other issues that really these patients may benefit from. A lot of people that are obese have sleep apnea. In the story, they have these huge problems with knees and other joints, that weight-bearing joints. A lot of those things come into play, and I just want to make sure I want to mention real quick right now that there are other ongoing studies to see where GLP-1, the GIPs and the GLPs are being utilized or can be utilized, and in terms of decreasing risk health outcomes. Believe it or not, Linda mentioned, somebody mentioned it earlier, I think it was Linda, mentioned substance abuse, because they did a study and they had some rats that they gave crack cocaine, and they had some of them that they gave the sugar. And, all but one of the rats decided they wanted the sugar, so you start looking at these carbs, and these things work along the line of reducing the effect that carbs have on your whole body, blah, 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 blah. The other thing is decreasing risk or risk reduction for mental health, including suicidal ideation, schizophrenia, psychotic disorders,
Parkinson's,
other neurocognitive disease, including Alzheimer's, okay, the so-called type 3 diabetes that people talk about. There's some infectious diseases that they talk about risk reductions, like pneumonias, cardiovascular events that is kind of understandable. Cardiac arrest, ischemic strokes, strokes that occur as a result of decreased blood flow to the brain, chronic kidney disease, they're decreasing, as a risk reduction with those, COPD for those who previously smoked, chronic obstructive pulmonary disease, the people, smoking related issues. There's also coagulation disorders that decrease, there's a risk reduction with it, blood clots, embolisms, blood clots, stuff of that nature. And so those are the many fronts in which they are looking at the the GIPs and the GLIPs, i.e. for those that just joined us lately, Ozempic and things of that nature, that they are looking that are really promising for treatment. Now, as Linda said, there can be some issues associated with them. And we need to, as a team, the pharmacist, the dietitian, okay, especially a primary care physician, not just waiting until you get to a bariatric surgeon and stuff of that nature. There are, and a mental health counselor. That team needs to probably be involved in these people trying to get these risk reductions.
Yeah, Rebecca, you mentioned that you have experience with clinical trials. Why is it important for people to participate in clinical trials so that the industry will know more about the risk and benefits of these medications with various populations? Or did I just answer the question?
Yeah, you did, but that's exactly right. Is we want to make sure that we're studying these medications and a well-represented population for who's going to be using the medications. And so, if the studies are looking at 90% Caucasian white people, like that's not going to show how Black, African American people, Asian, Native Americans are responding to these medications. I mean, I think now in 2025, we know that patients do respond very differently to certain medications. Even within the same drug class, the same person can respond differently. And so it's just really important that we're seeing how they're breaking down the medication and metabolizing it. And so there are a lot of clinical trials that are out there, and the FDA has a lot of mandates out there that we focus on enrolling patients that are more representative of the patient population. So, I'm actually local in Jacksonville here, and we've been working on semaglutide, like I said, for the last 12 years, and we're actually working on another one. It's called retatrutide. So now we've got a GLP, a GIP, and glucagon. So there's 3 kind of components to how this medication works. So we're studying that in Jacksonville, and if patients want to enroll, so Dr. Mills and Dr. Kane, looking for patients that are not only obese but overweight, if they have had like a heart attack, a stroke, if they've got kidney disease. So again, we talked about these comorbidities. So if patients are not just overweight or obese and they've got these comorbidities, that's really what we're looking at, reducing their events, reducing more events, reducing the first events in these patients. And hopefully the more data that's out there, then insurance companies will have more, like they have to support it. If it's going to prevent heart attacks and strokes and dialysis and things in these patients, like it's great that they're losing weight, but it's even better that they're not going to have heart attacks. So there's just, data is very important, from an insurance standpoint, but of course from like a physician standpoint.
Let me make sure I put my little 2 cents in. I'm gonna be brief as possible. As Rebecca knows, I've been I'm a proponent of clinical research, but being a proponent of it makes sure that me or people like Dr. Mills are the people to help oversee what is going on with their patients in the arena of clinical research. You don't just throw them to the lions and let them go on ahead and participate in their study. And I know that East Coast Clinical Research also I've worked with them in the past, and I keep a very good eye on my patients, and I'm very selective who I refer them to. I refer to them and whom I refer my patients to, because we do need more information on what works for us as a group of people. For years they came out with, take this for your high blood pressure, or take this for your diabetes, and take that. And the studies were only done, 90% of them were white men. They didn't include women. They did not include Black folks or other minorities. And 90% of them were white men. So how can I sit back as a clinician and go back and start prescribing stuff that I don't really know if it's going to work in my clientele, other than what Big Pharma has told me. So unless they've done the clinical research to show me how it works in African Americans, as you know on this podcast, how it works in Black folks, then I'm not interested in participating in that trial. And I've worked with East Coast Clinical Research for some time, and they've done, and Rebecca's co I don't want to say boss because I don't know where it stands. But Ruship and I have known each other for some time, and he knows, yeah, I refer patients in to you, but I'm not going to just refer them arbitrarily because you got a study going on. I want to know about the study. I want to know what's going on with the study, and then I can refer patients into you. And I think Dr. Mills feels the same way because he's concerned about his patients.
Mm-hmm.
Linda, I want to ask you a question because we've talked a lot about the Ozempic, Mounjaro, and those medications, but are there any particular or popular diets you feel are particularly effective, and why?
And wait a minute, Linda, before you ask me, can you contrast high fat diets and fat
That's not
versus
really my
carb
question,
diets,
no, that's not really my
low fat
question, Dr.
versus low
Kane.
carb.
You changing my question, Dr. Kane. I want to know, are there any particular popular diets other than
High fat and low carb is what the popularity
that
is
are
about.
effective?
Honestly, I try to get people away from fads. I try to in the assessment that I do, I do have some algorithms, and I figure out what your caloric needs actually are. Once I know what they are, then I show you how to have balance within that caloric level.
Mm-hmm.
So whatever the number comes out to be, depending on how much weight you need to lose, I'll subtract 500 to 750 calories from the total, and then that's what you get. So I show people how to get adequate, and my plans are higher in protein, but I do that because with any weight loss plan, you're going to lose muscle. So I want to mitigate that as much as possible. But protein also helps you feel full longer. And I want people feeling full after they eat this teeny weeny meal that they're going to get. And then by the time that gets digested, it's time for a snack. The snack has protein in it. Then it's time for lunch, and then that mid-afternoon snack has protein in it. But what people learn to do is they learn how to eat a balanced meal. And so it does involve some cooking. It does involve some planning. I have a lot of clients that are salesmen, they're truck drivers, they're on the road, and so I can tell you every rest stop between here and New York City, and between here and Los Angeles, because it's all planned. It's all planned. So what they're doing at the rest stops, if they're driving an 18 wheeler, what they're doing at the rest stops is they are walking. So we plan 15-minute walks at these rest stops, so I can tell you where they are. But the whole goal is because what you're supposed to be doing when you eat is getting all of your vitamins and minerals and nutrients. And so people have gone the way of people doing keto. Honestly, if a client says to me, I want you to help me do keto, I'll say, go find somebody else. I will not do that. And the reason why I will not do that is because, again, you're going to win the battle and lose the war. That person is increasing their risk of a cardiac event. By following that meal plan, they're increasing their risk of cancer. So, because if you do keto, you're eating all these free radicals, but you're not eating enough fruits and vegetables to counteract the free radicals. So mine is all about balance. So I don't have a, if you pressed me on what plan would it be, it would be Mediterranean. If you press me to give a name, it would be Mediterranean. but what we do in my practice is it is customized, it is individualized. So it looks at, people have been on diets forever, and I'll say, okay, which one worked the best? And so that kind of gives me a window into how they process things. And so we tailor the meal plan to the person. So I am not about fads. People are into intermittent fasting. That is absolutely fine. But when you are doing intermittent fasting, you are eating the same foods. You're just eating them in a different time frame.
So we are at the end of the show. I mean, it literally is 7:30, and we like to be respectful of time, and we always know when it comes to hot topics like this one, it's going to take more than 2 episodes, Dr. Mills. I know this is your second time, but you're forewarned that we're probably going to need a third episode. So let's just go ahead and tell you, and bring your wife back this time so she can give her perspective on the business. But we thank you all for sharing your expertise and your perspective, and we hope that our guests got some good information tonight. We know this is a very complex topic,
Yeah.
so we'd like to give our guests an opportunity at the end to give a shameless plug for the companies that they work for, they're representing tonight, and also give your final thoughts regarding tonight's conversation. I'm going to start with Linda. I'll repeat and repeat and repeat person. What are your final thoughts? And go ahead and do a shameless plug and point people to you and sign at um,
Well,
that.
here's my shameless plug. Sign at Registered Dietitians. We've been around since 1985, so we're not newbies. We are skilled at what we do. You should start seeing the TV commercials on February the 15th in the Jacksonville area, because what we do is different. And what the difference is, we look at you as an individual, and we start with a blank sheet of paper, and we develop the meal plan after you've been assessed. If I had one thing to sort of close out with, it would be everyone that wants to lose weight needs to call their insurance company, ask their employer if they have employer based um, health insurance, and demand that services of a registered dietitian be covered in network. So that's my final answer.
Seems like a no-brainer, doesn't it? That the
At least
dietitian
to
is a
us,
part of
anyway.
the,
At
yeah, an
least to
integral
us.
part, yeah, an integral part of your medical team. Rebecca, what are your final thoughts and shameless plug for
Yeah.
as we close tonight's topic?
Shameless plug is I am with East Coast Institute for Research. We've been conducting clinical trials in Northeast Florida for about 18 years now. A lot of these medications, but other medications that are used to treat different heart conditions and diabetes and you name it. We care for our patients very much so. And so, like, when our patients come through our door, whether it comes from Dr. Kane or Dr. Mills, like, we work really closely with the providers in the area that are setting the patients, and we make sure that they're treated really well and followed up for safety and everything along those lines. I think with all medications, there's the benefits that I think are really well known, obviously, with these, like obesity and the weight loss, but the blood sugar control, the high blood pressure, etc. But also being aware of like the potential side effects or the concerns, as Linda had brought up. And so don't go into these medications blindly. But talk to your healthcare providers and your pharmacists and your registered dietitians, and seeing how you can be, kind of a healthier individual as a whole, and not just rely on the medication. So would be happy for anyone to kind of reach out to us if you're interested in clinical trials. Like we have some right now for these medications. So reach out.
Thank you so much, Rebecca. And Dr. Mills, what are your final thoughts and shameless plug for your businesses since you have more than one?
I know, man. I'm working too much. I'm trying to be like Dr. Kane. Um,
I'm
so
not Jamaican, by the way. Go ahead.
hey, my wife is. I need to get her to work.
Yeah, yeah. You know
But
what they say about us. Yeah.
I know, right? So, like I said, we just opened Slim Glow Medical about a month ago, but I've been in practice doing this for about not as long as Dr. King yet, but I've been doing it for a while. And so, we're just trying to keep everybody healthy. And I just want to be able to give people the opportunity who want to be on these medications to safely be on them and, get them hooked up with people like Mrs. Brown or Dr. Goldfein as we need to. But like I said, these medications work very well. There's multiple indications. There are going to be multiple more that keep coming up. Like you said, now they're being indicated for sleep apnea, and I have patients come to me and tell me that now they don't want to drink, since they've been on the medications, and so there's going to be multiple indications of these medications as they keep, as we keep getting more and more information on them. But like I said, we'd be happy to help anyone out who their insurance doesn't cover, and they want to lose some weight. Like I said, Slim Glow Medical. It's 518. 5868 is the number. And thanks for the time, you guys.
Thank you, Dr. Mills. And Dr. Kane, what are your final thoughts? I see you looking over at your notes. You would take notes during the
Yeah,
show.
yeah. This is because I want to remind myself of something to say. But these guys, ladies and gentlemen, sorry, they were not chosen arbitrarily. They were chosen because of the expertise in which they deal with. Research we definitely need because we won't know how things work if we hadn't looked into it, or how well things work if we hadn't at least researched that aspect. When it comes down to dietitians or dietary related issues, we have to have dietitians involved. And then myself and Dr. Mills are both primary care because we reach the whole gamut. Being jack of all trades and master of none, we wear many hats, and sometimes we should not be wearing all the hats. Mm-hmm. We need assistance in doing it. And so when it comes down to these particular drugs, or any medical condition, to be quite frank with you, one, we need to know what the research background on it and or what are the ongoing research entities or ongoing research projects are going on. Two, we need to make sure in terms of dietitians or dietary needs for our patients that are being met. And I am not a dietitian. I'm not smart enough to be one. So I need the assistance, okay, of a dietitian. And then going back, even though I said research, we still got a pharmacist. That's what we got to remember. My original, where I started at was pharmacy. I understand the importance of pharmacy. So I'm always trying to make sure people can appreciate what pharmacists can offer in terms of assisting them with taking care of their patients. And then finally, like Dr. Mills, myself, we're primary care physicians, jack of all trades, master of none, but we have to sit back and try to keep our patients out of harm's way, not just wait until they get into harm's way to treat them. So everybody on this podcast was chosen for a particular reason, and I think that we have fulfilled why we wanted them on this podcast.
Thank you, Dr. Kane. Thank you to our pharmacist, Rebecca Goldfaden, our registered and licensed dietitian, Linda Lockett Brown, and of course, our two wonderful, distinguished primary care physicians, Dr.
Certified, Dr. Mills, certified,
and Dr. Rogers Kane. Tonight, we explored the complexity of obesity, from its causes and health consequences to the many tools available for treatment, including pharmacotherapy, dietary strategies, and the importance of a collaborative care approach. If you or someone you know is struggling with obesity, remember that help is available, and sustainable solutions often come from a team effort involving dietitians, pharmacists, physicians, and other professionals. Stay tuned for our next episode of Pause for the Truth. If you have not subscribed to us on YouTube, please do so to make sure that we widen our audience and let people hear experts such as these in future episodes. By the way, this is our 169th episode. We
Wow.
started doing the podcast during COVID-19 because we wanted to help the community, educate them first on COVID. And it's evolved because, as you can tell from the conversations that we have with the experts that we bring on, the complexities that are involved with managing one's health and the societal issues that happen are just happening all the time. And so this is a platform that we like to have those hard discussions. Thank you for tuning in to Pause for the Truth. And of course, thank you to our behind the scenes technology wizard called Tyrone Jackson. We appreciate the hard work he does in keeping us on the air. Thank you to our guests. Have a good evening.
Thank you.
Hold tight, guys. If you can give me just 2 minutes afterwards. Thank you.
And there we have it, another episode of the Pause for the Truth podcast in the proverbial books. Our heartfelt thanks go out to every one of you who took the time to tune in. Mark your calendars, we're here every Tuesday at 6:30 Eastern Standard Time. Feel free to join our community on Facebook, Twitter, and LinkedIn. But the golden ticket? Subscribing to our YouTube channel. That's your passport to all our latest episodes and exclusive content. A special mention to the wizard behind the curtain, Tyrone Jackson from Call Tyrone IT Services. His technical prowess and unwavering dedication are the backbone of this podcast. Next week, we'll be back with more. Until then, tell your friends, tell your family about our show. Your support is invaluable. And remember, keep that curiosity alive. Keep seeking the truth.